Thank you, Martin, and again, welcome everybody. It's great to see such a large turnout here in person and on the webcast as well. This talk is going to be addressing the first two normative questions that Jeremy laid out in his presentation, namely, who is a research subject in cluster randomized trials? And once we have that question figured out, when and from whom is informed consent required? So, as Alan alluded to in his presentation, in a traditional individual patient randomized controlled trial or most other types of human subjects research, it's generally pretty obvious who the research subject is. We recruit them, we randomize them to one or another intervention arms and follow them prospectively and collect data. Whereas in cluster randomized trials, the question is a little bit more complicated because often the cluster trial intervenes on a variety of individuals and not just the cluster members, whether they be patients or students or citizens or prisoners or members of a baseball team or whatever cluster that you're looking at. But you can also intervene on other individuals to produce a cluster level effect. So for example, you can intervene on physicians to produce a cluster level effect on patients. You can intervene on teachers to produce a cluster level effect on students and so on. And so it really is a more challenging question, just who is a research subject in these kind of studies. And so we need some sort of means for actually trying to figure out just who is the research subject here. And there's a bit of an assumption, I think, in the small but growing cluster trial literature that cluster members are necessarily subjects. And I think we need to question that assumption a little bit. So are all cluster members necessarily subjects? And if not, how do we differentiate subjects versus non-subjects? And so we need some sort of device that allows investigators and research ethics boards to make that distinction. And it's an important question, and we didn't, until we actually got into this, we didn't realize just how important a question it was for a number of reasons. And that first and foremost, because when somebody is a research subject, then their interests are being threatened for the sake of scientific advancement. And so for that reason, they're entitled to regulatory protections, whether it's through federal regulations or international research guidelines. They're entitled to protections to ensure that they aren't unnecessarily exploited. And this gets to Dr. Saxena's question, does being a subject necessarily entail that you need informed consent? But it's about more than just informed consent. And it's also about ensuring that subjects are presented with a reasonable balance of harms and potential benefits, and to ensure that they're chosen fairly and so that they're not exploited unnecessarily. And so, yes, there are issues of consent, but there are other issues that go along with being a research subject that have to be considered. And so we need to be really clear about who a research subject is before we can consider any of those other issues like consent and harm-benefit analysis and so on, like you're going to hear about later today. It's also a high-stakes question. Think about what happens if we get this question wrong, and Jeremy alluded to this as well. If we don't identify everybody who ought to be considered a research subject, then we leave people vulnerable to potential harm and preventable exploitation. But on the other hand, if we're overly inclusive and calling everybody a research subject, then we're probably going to put inappropriate constraints on research and so hamper the development of scientific knowledge. And so we really do need to get this question right from the get-go, and I think that's why we wanted to address this question first before we moved on to any of the more bread and butter bioethics questions like consent and harm-benefit analysis. So I think what we need is to arrive at some sort of comprehensive definition of what a research subject is. And if you look at the various national, international research ethics guidelines, if you try to find a definition of research subjects, you're going to be looking for a long time because there isn't much out there. So there is a definition in US federal regulations, and there are some brief definitions in FDA regulations. But if you look at the major other national, international guidelines, you're not going to find a whole lot. And what you see in US federal regulations is a list-based definition. So there's a list of things that is sort of, if you have these things done to you, then you're or a research subject. And so it doesn't provide us with a whole lot from a conceptual point of view. It doesn't provide us with a lot of sort of a conceptual background to be able to identify research subjects if something that is germane to a cluster trial isn't on that particular list. And so what we felt we needed is a comprehensive big picture definition of what a research subject is, and that'll allow us to do a couple of things. It'll allow us to identify research subjects in any novel field of human subjects research, of which cluster trials are just one example. And it'll also allow us to evaluate the adequacy of list-based regulations, such as in U.S. federal regulations. So the way that we sought to arrive at this comprehensive definition of a research subject is to take a look at clinical research and think about what's the difference between being a patient and being a subject in a clinical trial. And so if you're a patient in a medical practice, then you have a physician who's acting solely in your best interest. And same thing if in the setting of education, if you're a student, then you have an education system and a teacher and a principal and so on who are supposed to be acting in your interests. And there's that promoting your interest is basically the essence of their job. Whereas if you're a subject in a clinical trial, this is a systematic investigation designed to develop generalizable knowledge, and for that reason, your interests, be they welfare interests, privacy interests, or what have you, may be compromised for scientific purposes. And so it's not the case that your interests are the sole goal of the activity. The goal is to develop generalizable knowledge, and people may be taking your interests at heart, but the primary purpose is to develop scientific knowledge. And so we're going to propose this very broad definition of a research subject that we'll try to specify in a bit more detail shortly. That a research subject is any individual whose interests may be compromised as a result of interventions in a research study. And when we say interests, we're meaning this to be taken quite broadly, whether they're welfare interests, whether they're privacy interests. You could conceivably think of economic interests, because cluster trials have been used in field studies of economic policy and so on. And so the term interest, we intend to be construed quite broadly. So if you look at U.S. federal regulations, this is the list-based definition. What it says is that a research subject is a living individual about whom an investigator obtains data, either through intervention or interaction with the individual, or identifiable private information. And so essentially what's happening here in these federal regulations is that it's specifying ways in which individuals' interests might be compromised for research purposes. And so this is sort of a list-based definition that gets at what actually, or sort of operationalizes what it means to have your interests compromised. They further go on to define intervention as any kind of manipulation of the subject or the subject's environment. And this is going to be important as far as cluster trials and public health research is concerned, because we also need to be clear about what manipulation of the environment means. And so what does environmental manipulation mean? It surely can't be any environmental manipulation. So to use a bit of a facetious example, right now in Switzerland, they're doing particle acceleration experiments at the Large Hadron Collider facility that could theoretically create microscopic black holes that could expand and wipe out all life on Earth. So are we all research subjects of the Large Hadron Collider experiments? And I think just the ridiculousness of that notion leads us to conclude that we probably need to specify a little bit more tightly what actually counts as an important environmental manipulation as far as research goes. And so we're going to propose that environmental manipulations need to be designed to affect target individuals, i.e. cluster members, and must also jeopardize their interests. So to specify this a bit more tightly, what we're trying to get at is that for an environmental manipulation to count, it needs to be an intervention on an individual via manipulating their environment. And so this is what I think sort of encompasses what a lot of large public health trials like the COMMIT trial did with public health messages and so on. And so this is sort of what we'd be getting at in terms of thinking of environmental manipulation that's sufficiently meaningful to make somebody a research subject. How about patients whose professionals participate in a cluster randomized trial? So there was one example that Jeremy had was of a study in which physicians were intervened upon to improve their prescribing practices for patients with diabetes and cardiovascular disease. So are all of those patients in those physician practices necessarily research subjects? The only paper that really addressed this question came out in 2008 in IRB, and the authors argued that these indirect effects on patient care that stem from intervening on healthcare professionals might be construed as constituting an environmental manipulation. And if that's the case, then we need to think about those patients as being research subjects. We're going to counter that argument by saying that even if you intervene on a health professional, those professionals are still bound to act in those patients' best interest. And so the way that they treat individual patients may be influenced by the cluster trial intervention, or it might not. And that depends on whether those patients' interests are served by having their care influenced by the cluster trial intervention. And so there's a buffer there between the study team and between the patient, and that's the professional or the teacher or what have you, who's obligated to act in those cluster members' best interest. And so even if you grant that this is an environmental manipulation, those patients' interests aren't jeopardized just by the fact that their health professional is participating in the cluster trial. So what we're going to argue is that patients of professionals who are intervened on aren't necessarily subjects, but they could be if they're intervened upon in other ways, like using identifiable private information. So we're going to define a research subject as an individual whose interests might be compromised as a result of interventions in a research study. And this can happen in a number of ways. If they're directly intervened upon by a researcher, or if they're intervened upon via manipulation of their environment, if they interact with a researcher for the purpose of data collection. And so in the COMMIT study, they evaluated outcomes by surveying a random sample of smokers in each community, or if an investigator obtains identifiable private information. So these specify ways in which an individual's interests might be compromised. So that's the operational definition of research subject that we're going to be working with and using to identify research subjects in the example cluster trials that Jeremy outlined. This definition has a number of implications for cluster trials. Cluster members may or may not meet the definition of a research subject. So it's not necessarily the case that every cluster member is necessarily a research subject. The implication for that being is that if you're not a research subject, then consent is not required, and we don't need to think about things like harm-benefit analysis. Patients of professionals participating in cluster trials aren't subjects unless they meet other criteria, like having identifiable private information used or interacting with the study team. On the other hand, if you're intervening on professionals to produce some sort of cluster level effect, then those professionals are research subjects themselves. And consent is a separable issue that we're going to talk about right now. So there's a number of challenges in obtaining consent from research subjects in cluster randomized trials, and they've been laid out in the literature reasonably well, and raised by people who've asked questions so far this session and from the webcast as well. First is sometimes seeking consent just isn't feasible. So some cluster level interventions just aren't avoidable. So things like water treatment or spraying pesticides to reduce malaria rates, that kind of thing, they're very difficult for individual cluster members to avoid. So in that sense, it doesn't really mean anything whether you give or whether you don't give consent, because you can't avoid it anyway. Related to that, and usually happens in public health trials, is that clusters are so incredibly large, so if you're randomizing entire communities, it can be extraordinarily difficult from a logistical perspective to try to identify and seek consent from every single individual who might be a research subject. So for large clusters, it can be very difficult to seek informed consent. Another issue has been raised is the potential for bias, and this is particularly in the case of cluster trials of behavioral interventions. There's a concern that if you undertake a detailed informed consent process by informing subjects of what's going on in their trial arm as well as what's going on in other trial arms, then those subjects may actively seek out what's going on in the other trial arm and potentially dilute the effect of the intervention that you're trying to study. And so there's been a concern raised by methodologists primarily about whether a detailed informed consent process may actually bias the results of behavioral intervention studies. The other key issue or key challenge in a number of cluster randomized trials is that it's just not possible to seek consent prior to randomization of clusters because subjects might not even be identifiable. So one good example is a trial that was done in Nepal and published probably about 5 years ago that randomized communities for women who are giving birth to use one of 3 different strategies for cleaning the child's umbilical stumps after they're born. And communities were randomized to one of 3 arms even before women became pregnant. And so it was just impossible to identify subjects and seek their consent at the time of randomization. So the only option is to seek consent after randomization of clusters. And so hasn't really been well addressed whether seeking consent after cluster randomization is okay. So in addressing these challenges, we're going to try to keep in mind just what informed consent is for. And so when you seek informed consent, what you're doing is respecting the choices of autonomous individuals. And this means that you're treating the research subject as a person and not merely as means to an end. And so what you're doing is that you're allowing them to adopt the ends of the study as their own. And so this partially justifies exposing them to risks for the benefit of others. And so you're allowing people to choose to be part of the study because that's congruous with their own particular set of values. And so you're not treating them as means to an end because they're agreeing to participate. But what about situations where consent is not feasible? And so this is where a number of regulatory waivers of consent may come into play. You do see waivers of consent in many national research guidelines and regulations, as well as international guidelines such as the CIOMS guidelines. And we can they're all worded a little bit differently, but what they generally put out is that a waiver of consent is permitted in a couple of specific circumstances. First, if the research is absolutely not feasible without the waiver, and second, if the research poses only minimal risk to subjects. And we're going to talk a little bit about what each of those things mean. And so feasibility, like we talked about, it may be logistically impossible to seek consent from all subjects. Sometimes if there's a cluster level intervention that can't be avoided, then refusal is just plain meaningless. And also there's this potential for bias to invalidate findings. I think the first 2 scenarios, I think we need to seriously consider that these may be legitimate reasons for seeking a waiver of consent. I think as the panel deliberates, we need to talk a little bit more about how much weight do we want to put on the potential for bias to invalidate findings. And I'll talk a little bit about one potential remedy for that, because I don't think we want to leave open the door for anybody to say, well, there may be some small degree of bias in my findings because of the consent process, so I think we just want to waive consent. I don't think we want to leave that door wide open, and we'll be talking in a little bit about ways that we might actually alleviate that concern. So those are the conditions of lack of feasibility. What minimal risk refers to is generally the risks of everyday life, including routine medical examinations and tests. And so we can paraphrase this, is that the interventions we think need to be consistent with competent medical practice or public health practice or education practice, whatever the field of that particular cluster trial is. And so if seeking consent just isn't feasible, and if it poses only minimal risk to subjects, then it may be reasonable to waive some or all of the requirements for informed consent for a particular cluster randomized trial. The next issue is, may consent be sought after randomization of clusters? And Dr. Tugwell brought this up in the first question period. A number of people have cited the Zelen design, which has been used in individually randomized trials, as a potential remedy to this particular concern. So in the Zelen design, what happens is that randomization occurs, and people who've been randomized to the intervention arm, consent is then sought and they're followed prospectively, whereas in the control arm or placebo arm or what have you, consent is not sought. And so what the Zelen design was specifically developed for was essentially to increase accrual rates in clinical trials. And I think that's a bit of a different problem that we're facing here, because what they're doing is, even though they could seek consent prior to randomization, they've chosen not to. Whereas the issue in cluster randomized trials is that even if you wanted to seek consent prior to randomization, you can't. And so it's a separate issue. I don't think the Zelen design actually addresses the issue at hand in terms of, can you actually seek consent after randomization of clusters, because that's your only choice. And so if seeking consent after randomization of clusters is your only choice, I think it's probably okay. And the reason for that is that even though you know the arm of the study that your cluster has been assigned to, you as a potential research subject can still choose whether or not to participate in the study. You can still choose to adopt the study ends as your own or not, with the knowledge of the cluster assignment. So it doesn't threaten your individual autonomy to say, okay, I'm going to choose to participate in this trial or not. Your choice is simply, I'm going to choose to participate in the arm that my cluster has been assigned to, or I'm not going to choose to participate, as opposed to I'm going to choose to participate and be randomized to one arm of the trial or another. And so you're still making a decision whether or not you're going to participate in a particular trial, the difference being that you just know which arm your cluster has been assigned to, and your choice to opt out still exists. If you are seeking consent after randomization of clusters, then you need to seek consent as soon as possible after randomization and before any study interventions occur. And this is another key difference between what we're proposing and the Zelen design, is that there may be some study interventions that would have taken place prior to consent if the Zelen design were undertaken. This is different. You're seeking consent as soon as possible after randomization and before any study interventions take place, and that way you're ensuring that people are being treated as means rather than as ends. On a related note, if you're enrolling subjects after randomization of clusters, what do you need to tell them? If you're in a traditional randomized controlled trial, you need to tell people the purpose of the study and what could happen in any of the study arms that they could potentially be assigned to. But if you're enrolling subjects after clusters have been randomized, then cluster allocation is already known. And so do you need to tell them anything different? And so we're going to argue that you need to tell them the purpose of the study. They need to know in detail the risks and benefits of the interventions in the study arm to which their cluster has been assigned, what their options are if they choose not to participate. And so people need to know that even though their cluster has been assigned to a particular arm, they can still choose not to participate if they don't want to. And we're going to argue that detailed information about what's going on in other arms of the trial that they couldn't possibly have access to is really immaterial to their decision. And so they don't need a great deal of detailed information about what's going on in Arm A if their cluster has been randomized to Arm B, because they're never going to get what's going on in Arm A anyways. And so there isn't really a need to provide them detailed information. Their choice is whether or not to participate in Arm B or not. What happens in Arm A really is immaterial to their decision. And I think knowing this is that there's a potential to limit that response bias concern that some methodologists were concerned about if you're not providing a great deal of detailed information about what's going on in other arms that they couldn't possibly ever be randomized to anyway. A brief word about passive consent mechanisms. This is often used in school-based studies. And so what passive consent is that information is distributed to parents or to the group of potential subjects. And then potential subjects are asked to contact the study team to opt out if they really don't want to take part. And some of the challenges to passive consent mechanisms are that it's unclear if potential subjects are adequately informed enough to make a decision whether they want to participate or not. It's hard to know what does a non-response mean. Are they agreeing to participate, or did they just not get the information? It's hard to know. And the other disadvantage, I guess, is that a passive consent mechanism is an alteration of normal consent processes, and so it's subject to the same regulatory restrictions as a waiver of consent is. So from a logistical point of view, you can't do anything more to somebody in a passive consent study than you can in a waiver of consent study. So it's not really clear whether there's any actual value added to a passive consent strategy. Some people may argue that for those who actually agree to participate using a passive consent mechanism, that's more respectful of their autonomy. And maybe if they were adequately informed through whatever information dissemination process that the study used. So they may have made an informed decision to participate, or they may have made an uninformed decision to participate, and you can't tell which is which. And so it's not really clear to us whether there's any value added to a passive consent process over and above a waiver of consent. And I think that's something that the group, as it goes forward in its discussions over the next couple of days, probably wants to talk about. So as a general rule, we need to get consent from research subjects, whether they be cluster members or whether they be professionals. A waiver of consent might be permissible if consent is not feasible and if the interventions in the study only pose minimal risk. And subjects may provide consent after cluster randomization if that's the only option, and if they're informed as soon as possible after they've been enrolled. So just to go through the couple of example studies, the COMMIT trial that Jeremy introduced and Alan introduced, in which communities were randomized to a variety of mass media campaigns and targeted public health strategies. So intervention communities, they got all this targeted messaging and that kind of thing. So you could construe that as an environmental manipulation. And so you could make a reasonable argument that every citizen in an intervention community is in fact a research subject. But if you're in a control community that got nothing, then there really isn't any kind of environmental manipulation or anything that might jeopardize your interests. And so you're not a subject unless you were one of those sample of 1,000 smokers that got interviewed, or one of those sample of community members that got a telephone call. As far as consent goes, you can imagine it would be quite logistically difficult to seek consent from every single person in an intervention community. And the interventions that we're talking about are quite minimal risk, and so I think it's reasonable to go ahead with a waiver of consent. Whereas if you were actually interviewed, then that opportunity exists to seek your consent, whether it's verbal or written or what have you. And so we'd argue that you only really need to get consent from the subjects who were actually interviewed. The malaria bed net study, in which communities were randomized to receive treated bed nets, and then they ascertained outcomes with blood samples from a sample of each community. So obviously the residents of intervention communities who got the bed nets, they're getting an experimental intervention, so they're research subjects. But in control communities who got nothing, then the only people who you could consider research subjects would be those who are actually approached to give blood samples. And it's whether or not it was feasible to get consent for the bed net distribution kind of depends on the method that they use to distribute those bed nets. So a waiver might be appropriate, or you might be able to get consent from intervention community residents, depending on how you actually distributed the bed nets. And obviously anyone who gave blood samples, the opportunity would exist to give consent for that. Whereas the trial of primary care prescribing, in which physicians were intervened upon with a number of educational approaches to improve the prescribing for cardiovascular disease and diabetes, the physicians were the ones who were actually receiving the experimental interventions, and so they are the research subjects. Whereas the subjects, nothing really happened to them. Their care may or may not have been influenced by the physicians, the intervention on physicians. There wasn't any identifiable private information collected, and the patients didn't really interact with the study team in any way. And so we would argue that those, in this particular case, that the patients of the physicians who are intervened upon are not subjects, and so you would not need to seek their consent. However, you would need to seek consent from the physicians. And so that's how we've approached these 3 prototypical trials, and looking forward to hearing Kathy's comments and everybody else's comments at the end of the session.